بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف خلق الله والمرسلين سيدنا محمد وعلى آله وصحبه وسلم تسليما كثيرا. السلام عليكم ورحمة الله وبركاته جميعا، ومساكم الله بالخيرات. الصوت مسموع؟
مسموع كويس أوي.
تمام. My screen is share.
أيوه شايفين، كلنا شايفين.
طيب.
تمام.
في البداية طبعا I have to thank my professor, my mentor, my role model, Professor Dr. حسن خالد، طبعا أستاذي وأخويا الكبير، وكلمات الشكر والتقدير طبعا لا تعطيه حقه، ولا زلت بعتبر أحد تلاميذه اللي بدين لهم بعد ربنا سبحانه وتعالى بالفضل. فشاكر جدا جدا دعوته الكريمة أن أكون اليوم سبيكر في الجورنال. اسم أستاذي وعزيزي على الكل هو دكتور حسن خالد. It's really my honor, it's really my great pleasure to be a speaker tonight among you. وأسأل الله تبارك وتعالى أن يعني ينفع بما قدمه الليلة، وأن يجعله في موازين حسنات الجميع، سواء الدكتور حسن أو المنظمين والقائمين على this fascinating weekly journal club. جزاكم الله كل خير. I hope tonight إن الله تعالى my lectures to be palatable, enjoyable. أنا عارف إنه موضوع very tough، زي المواضيع كتير في الآي سي يو بتكون tough، بس I hope tonight إن شاء الله تعالى إنه to have it يعني more simplified ومور enjoyable in next 30 or 40 minutes. طبعا التايتل هو about the IV diuresis or diuretics use in acute kidney injury. When as a time frame, how as a design, what are the common methods we face for practice in the critical care field. I have to highlight that I have no disclosure in my presentations. The objectives of my presentation, I will go through just a brief overview of the diuretics in AKI. دكتور حسن ودكتورة نجلة، بليز لو بس صوتي أو السلايدز مش واضحة بس بلغوني، أو أنا سريع ممكن حضرتك تنبهني كان سلو داون.
صوتك واضح جدا وهيخليهم صحيين لحد الآخر، والسلايد واضحة جدا. اتفضل.
واضح كده.
تمام. أوكي. The objectives of my presentation tonight, I'll just go through some highlight about the overview of the diuretics in the AKI. Then I will highlight the therapeutic role of the diuretics in the AKI regarding the volume management, the prevention of AKI, and any role for the treatment with diuretics in the established AKI. Then I will highlight some slides about the diuretics used for AKI boostation or the so-called Threshomite stress test or Threshomite challenge test. Some highlight about the so-called resistance, and I will highlight also the common methods about the intravenous Threshomite in the critically ill patients. Then I will sum up with some tips or tricks for the effective diuretic dosing in the settings of AKI. Let's start with brief overview of the diuretics in AKI. I will start with some brainstorming MCQ. This is a case of 75-year-old woman with the past medical history of CKD stage 3 CKD اللي هي chronic kidney disease, you know, of course, hypertensive, diabetic, coronary artery disease, and she had history of status post-CABG, was admitted to the ICU after developing sepsis due to community-acquired pneumonia requiring both vasopressors and intubation. The patient was noted to have decline or decrease in the urine output on day 3 of admission. Approximately it was 40 ml per hour, and her creatinine rose from 1.6 to 2 milligram per deciliter. Her PON was 40, and her potassium was 4 milliequivalent per liter, and her carbon dioxide, her bicarbonate was 23. Additionally, the patient was and the sacral edema. The question is, which of the following measures could help to improve the patient's survival? A, immediate initiation of renal replacement therapy. B, wait to initiate the renal replacement therapy until a clear clinical parameter. C, start IV furosemide infusion at 10 milligram per hour. D, none of the above. So just in 1 minute, I need some volunteers in the chat to put the most appropriate or correct answer for this MCQ.
D.
في ناس قالوا سي وفي ناس قالوا دي.
Okay. Any further volunteers? We have 70 attendees. We have only 2 answers. Don't be shy يا شباب. يعني it's not an exam. It's just for me. I'm just يعني reviewing with you. شباب الماستر وشباب الام دي وشباب الزملاء.
B.
Okay, so now we have B, C, D.
B.
Once more. Uh, 10 seconds for further contribution. Okay, I will leave the answer for the following slides. It will answer correct. So if we need to talk about some slides, in some slides about the epidemiology of AKI, the AKI, the so-called overall incidence in the critically ill patients is about 30 to 60%. So the incidence is not rare. It's about close to 2/3 here of critically ill patients, between 1/3 to 2/3, almost 30 to 6%. They develop AKI. What's the definition of AKI? To close the gap in the AKI and the CKD between acute kidney injury and chronic kidney disease. It's a time frame. So by definition, AKI episode that lasts longer than 7 days, but less than 90 days. So the time frame between 7 days to 90 days, we call it AKI. So if a patient during his ICU stay, starting from day 0 up to 90 days, we calculate now the episode of AKI. If he developed AKI that lasts longer than 7 days, but less than 90 days, so this is we call AKI. But the CKD or chronic kidney disease usually require a longer, which is 3 months or more to be diagnosed. So any AKI persists for more than 90 days, this is the term of CKD. This definition, usually it uses the creatinine criteria adopted from the KDICO definition. And I know that most of you are aware about the KDICO definition or the AKIN or AKI network definition. The diagnosis of AKI severity or the apparent recovery may be affected by the decline or decrease of the serum creatinine related to the muscle mass loss associated with chronic critical illness. So do not forget this important statement, because the long ICU stay or prolonged ICU stay or chronic patients in intermediate units or step down, or patients who develop critical illness, myopathy, difficult to wean, those patients, the diagnosis of AKI severity or apparent recovery may be affected by the serum creatinine, which is related to the muscle mass. And this is important when you calculate the GFR, either measured or the calculated. Moving to important entity or etiology related to the AKI, which is sepsis. What about sepsis-induced AKI? It's from 10 up to 67% of septic patients. About 2/3 of patients with sepsis or septic shock, they develop AKI. It carries an increased risk of mortality, fewer ventilator-free days, and longer hospital stays. So it carries both mortality and morbidity. So developing the AKI, or with so-called SAKI or sepsis-induced AKI, it carries both mortality and morbidity risk. And the morbidity risk related mainly for fewer ventilator-free days. The patient stays more on ventilator, in other words, plus a longer hospital stay, and this is reflected on the cost. An early event in the progression of sepsis. So this is one of the unique features of sepsis-induced AKI. It's an early event. Half of patients with septic shock, they develop AKI before the presentation to the ER. This is very interesting finding, that they found almost 50% of patients who came to the to ER with septic shock, they found that they have already established AKI before their presentation. So there is now a red flag about the AKI, that it may play a role in sepsis defining event. And maybe within 1, 2, 3 years or less, you may find a change or update in the sepsis definition or the sepsis guidelines regarding the red flags for sepsis. What I mean by playing a role of sepsis defining events, if you consider this is a red flag, analogous to الكناريز that alert the coal miners, الكناري أو طور الكناري بالنسبة لعمال الفحم، دي كانوا بيعتبروها يعني their tester for the presence of lethal toxins in the air. عشان كده لما كانت بتموت حوالي المناجم بتاع الفحم، فكانوا بيعتبروا ان تنقية pollution، فكان بيعتبروها one of the red flags. لو خدنا بالقياس، so the AKI may be an early sign alerting to the presence of sepsis وليس العكس، يعني cause and effect. My presentation will not highlight some pathophysiology or diagnosis, just I'm concentrating about the therapeutic intervention of the Use of Diuretics, بس هذا لا يمنع just highlighting to understand when to intervene with the diuresis or when to prevent before establishing the AKI. All of us, we know the pathophysiology of AKI. Here for the blue boxes, this is the contributing factors or the etiologies: low cardiac output state, the hypoperfusion or shock state, the venous congestion, nephrotoxic medications, baseline risk factors, age, diabetes, peripheral vascular disease, and so on. And the reversibility or progression if the patient developed just a fall in the GFR or glomerular filtration rate, or he developed tubular necrosis. And through this, how can you diagnose and you estimate through the serum creatinine or the biomarkers like NGAL or others? Then you estimate the pathological outcome through resolution or developing of end-stage kidney disease. And it varies between for recovery, subclinical, renal scarring, or remain patient with a CKD non-dialysis dependent, or it ends up by end-stage kidney disease. And this is related to all, either sepsis-induced, contrast-induced nephropathy, AKI related to shock state, whatever the AKI developed, this is the final outcome or the final destination. And to summarize this introduction, now you know the risk. Sorry, you know the incidence is quite considerable. It's between 30 to 6% in critical ill patients. So you have to identify the risk. Our patient at risk, you have to know exactly the cause so you can eliminate or you can nullify. Then you can prepare yourself. How can you prevent or you modulate a patient for recovery? And if the patient will not recover, hell is dialysis dependent or not, and or the patient will remain lifelong CKD, and by the end, is this patient at risk of mortality or not? So now we have to move for the next entity, which is just a brief overview about our shoulders for acute kidney injury, which is the IV diuretics. Just a reminder about the classification of the diuretics. We have carbonic anhydrase inhibitors, we have lobe diuretics, we have thiazide diuretics, we have potassium-sparing diuretics, and we have osmotic diuretics. If you remember from your third year during the medical school of pharmacology, and I think Dr. Najla, she is one of the best, so she can correct me if I'm wrong. This is a way how to classify based on the site of action. Carbonic anhydrase inhibitor, lobe diuretics, thiazide diuretics, potassium sparing, and osmotic diuresis. And here, through the illustration of the nephron, you should know when exactly when you give diuretics, when it acts. So here for proximal convoluted tubule, this is the role of acetazolamide or the carbonic anhydrase inhibitor, and it's considered as a weak diuretic. If you go for the ascending lobe of Henle, so you have the furosemide, the bumetanide. For the ascending lobe of Henle, you have the bumetanide and the furosemide and the torsemide, itacranic acid. Here they are acting here. While if you go for the DCT or the distal convoluted tubules, you will have the thiazide, and this is the most commonly diuretic used here for distal convoluted tubules. If you go for the collecting tubules, here is the role of the spironolactone or amiloride or trimethylene or the class of sparing, potassium sparing diuretic. So this is a very simplified diagram that depicts where exactly your diuretic is acting. Now I will move for, after this brief overview about the therapeutic role of diuretics in the AKI regarding the volume management. Is it a role for prevention of AKI? Or there is a role for treatment of established AKI. So to answer this, so I have to ask one question. If the fluid overload is toxic, if the fluid overload is toxic to an overall, I mean, increase intra-abdominal pressure, kidney or kidney congestion or renal congestion, lung issue. So is it a role here for diuretics to be beneficial if the volume overload is harmful? So this question was addressed to relate the diuretics to mortality and non-recovery of renal failure in AKI. This study was multi-center cohort, about 550 critical ill patients developed AKI. About 60% of them received diuretics at the time of nephro consultation. And you know, most of our nephro consultants or consultation likes the diuretics, especially if the patient on the positive balance side. They used the diuretics in the study in AKI, and they found that it was associated with increased risk of mortality and non-recovery of renal function. And the widespread of use of diuretics in critical ill patients with AKI should be discouraged. So this was early. If you look, this study published on JAMA in 2002. This was like, you can call 20 years back. So on those number of critical ill patients with AKI, this was their conclusion, findings and conclusion. They found that the diuretics in AKI, in general, it was associated with increased risk of mortality and non-recovery of renal failure. And they mentioned clearly in their conclusion that the widespread use of diuretics in critically ill patients with AKI should be discouraged or prohibited. طيب, الآن let's not to criticize the study, but just to go to some basics and to answer the question. So for the diuretics in AKI, really is a friend or foe or enemy? Let's go for the benefits of using the diuretics in AKI. Of course, it controls the volume overload. This is a conceivable benefit. It controls the volume overload, of course. For oliguric AKI or oliguric renal failure, it may convert to non-oliguric, and we face it a lot, and we watched a lot on patients who develop ATN, then with diuretics, they became non-oliguric despite rising the renal profile or renal chemistry. It reduced the renal energy expansion. It improved the GFR. How? By inhibiting the so-called TG feedback or Tupulo-Gallmiller feedback. Plus, the so-called, it improved that, or it caused what's called renal flushing. This is the beneficial effect. طيب, is it a harm? Yes. It precipitates, of course, or play a role of, if there is no wise use of diuretics in AKI, it will develop intravascular volume depletion. The non-oliguric AKI may reflect underlying severity of the illness, and it may delay the renal replacement therapy. And we have some recommendations or some evidence now about the role or the use of early renal replacement therapy in critically ill patients. And the nephroprotective mechanism, the so-called for the diuretics, is still unproven. So there is some thought about a role of nephroprotection or AKI prevention rule for the diuretics. They found that it was theoretically relevant and selected the high-risk AKI, but again, it's theoretically. Typically, was patient undergoing angiography. So the so-called renal guard or diuresis was hydration. For elective nephrotoxic drug administration like chemotherapy and patient with tumor lysis, and after cardiac surgery or open heart surgery. But the literatures and the evidence-based and the classical studies for prevention of radiocontrast nephropathy showed there is no benefit of IV diuretics. So for contrast-induced nephropathy, now there is no role for using IV diuresis and prevention. طيب, it's the next question. Do the diuretics in general have a role in treating already established AKI? So this was another cornerstone question, and published in the Journal of Critical Care 2017 through addressing the effect of low-dose Threshomite in critical ill patient with early AKI. And this is a famous study, which is called a multi-center double-blind placebo-controlled trial. 73 critical ill patients with AKI. They have early AKI through the rifle definition, and they have more than 2 search criteria, resuscitated with fluids. They have exclusion criteria. What are their exclusion criteria? The clinical need for Threshomite, recovery, recent RRT, and advanced CKD excluded from the study. They have the protocol for using the Threshomite IV, 0.4 milligram per kg bolus. So here they started with bolus, then 0.04 milligram per kg per hour versus the saline control arm. They titrated the diuresis to target a urine output, which is 1 to 2 ml per kg per hour, and the maximum dose was 0.4 milligram per kg per hour of Threshomite. The primary outcome for this is the progression of AKI. So this is what their primary outcome, and these are the summary of the study regarding the Threshomite versus the placebo group, and here p-value through worsening the AKI, cumulative fluid balance, kidney recovery, ICU mortality, received renal replacement therapy or not, hospital mortality, and also mortality at 90 days. And here there is no significant difference. So they concluded from the SPARC that the Threshomite, from the SPARC study, that the Threshomite did not reduce the rate of worsening of AKI, did not reduce the renal replacement therapy, did not improve the renal recovery. However, the electrolyte abnormalities were more frequent with the Threshomite arm, and this is very important or obvious. In 2019, there was one study that published in the American Journal American Society, Jason, that they want to simplify a stratifying risk score from the SPARC study. What they call it simple post-operative AKI risk for non-cardiac surgery. They need to have a predictive index or predictive score index for validation to delineate who is at risk of developing AKI or so-called the critical AKI. So this score, they call it a SPARC score. Through the age, they give the score 40 or above 80 and in between from 0 to 13. The GFR, they score the GFR, the dipstick albuminuria, the gender, the OR or the surgical duration in hours, either was elective or emergency. Here, for example, for emergency OR, the score 7 because the patient is not well prepared. The diabetes, the RAS score, the hypoalbuminemia, the anemia, and the hyponatremia. Through this SPARC score, they give a classification less than 20, 20 to 39, 40 to 59, and above or equal to 60. And they classify class A, class B, class C, class D, and this delineate the incidence and prognostication of developing the AKI. Through this simplified score, the same like you are calculating, for example, Chad-Vasc score or Hasbled score or ROX index score or Hakor score, it's the same. So it's a prediction score. And this score was adopted since 2019. They call the SPARC index for classification. It still needs some validation, but it's adopted. You may implement it or you may use the SPARC index and its classification to estimate what? To estimate the risk of post-operative AKI in surgical patient and its related outcome. Next question, what's the effect of diuretics as part of a broader volume management strategy? Now, if you have a patient with volume overload, what's the role of diuretics? So this study was addressing the issue of fluid balance, diuretic use and mortality in acute kidney injury. It's called a FACT AKI study. It was a comparison of restrictive versus liberal fluid management strategy in patients with acute lung injury. If you remember, for ERDS patient, there was a called FACT study. FACT study was restrictive versus liberal fluid management in ERDS, but there was sub-hoc analysis, or they call it sub study from FACT called FACT AKI. They compared the restrictive versus liberal fluid management in AKI, in acute lung injury, and what's its impact on the AKI. So the primary objective to elucidate the association between the fluid balance, either positive, negative, AO balance, the diuretic use, and the short-term mortality after AKI in critically ill patients. They concluded about 306 patients who developed AKI within 2 days of randomization. The 60-day mortality with 30% in both groups, almost 40% in the liberal, 37% in the restrictive. The post-AKI fluid balance was significantly associated with mortality, both the crowd and the adjusted. You know, the mortality has 2 types of mortality. We have crowd mortality and we have adjusted mortality. Crowd mortality is the general mortality. Adjusted is related to the disease itself. So the post-AKI fluid balance was significantly associated with mortality and reflected on both the crowd and the adjusted. Higher post-AKI furosemide doses had a protective effect on mortality, but there is no significant effect after adjustment for post-AKI fluid balance. When the adjusted has no effect on the fluid balance. There was no threshold in the SPARC study, in the FACT study, there was no threshold for the dose of furosemide above which the mortality increased. And this was important finding. They could not find a ceiling dose of furosemide that they could say that this is a threshold dose associated with mortality. They could not find this. Okay, now for a prognostication of AKI by the use of diuretics. Is it a role? Yes. We have the so-called, like the treadmill test or the challenge test or fluid challenge test. We have the so-called furosemide challenge test or furosemide stress test, FST. If you know that the AKI, especially early in phases or early stages, it may follow several courses. As we mentioned, may recover, may have ATN, may end by subclinical, may end by ATN, may end by CKD or dialysis dependency. The inability to forecast this progression of AKI is hampered by the development of the therapeutics. We don't have a lot of therapeutics in our hands, especially the diuretics. The response to the bolus of furosemide might help to anticipate the course of AKI episode, and I will show you how they delineate this in the furosemide challenge or furosemide stress test. The diuretic response is considered as a surrogate, يعني بديل, for the renal tubular integrity. The diuretic response in terms of urine output is considered as a surrogate for renal tubular integrity. So this is the protocol, how we use or how they do the furosemide stress test or furosemide challenge test. The dose of the furosemide, it depends on the patient received loop diuretics within 1 to 7 days before testing or not. So this is the question you will be answered to define the dose, how much you will give. So you have to know your patient. This patient was before on loop diuretics or not. So for the diagnosis, if the patient diagnosed as AKI based on the Aiken criteria, stage 1 or stage 2, so you have to classify your patient. Is the patient is furosemide naive? What does it mean? That the patient did not receive loop diuretics during this week or day 1 to day 7. So you will give the dose 1 milligram per kg. Okay. Or if the patient be treated with any loop diuretics during the first 7 days before the test, so you will give the dose of 1.5. So either 1 milligram per kg for the naive who did not receive before any loop diuretics, or you will 1.5 milligram per kg of what? Of furosemide. Then, after giving either dose according to naive or pre-treated, so urine output will be quantified until the next hours after drug administration. You will wait for 2 hours to judge for the response. What's your response target and what's your aim? Urine volume equal or more than 200 ml or 100 ml per hour. يبقى 200 200 100 100 per hour. Then the next 2 hours following the administration. If positive, this means that this is a loop diuretic responsive. If no, this is a loop diuretic irresponsive. The same like as you assess fluid responsiveness or fluid unresponsiveness. Here, LD or loop diuretic responsive or no loop diuretic irresponsive. Dr. Hassan, do I still have time ولا time is out?
You have time. احنا دايما بنقعد الساعة 11. عندنا 10 دقايق.
حاضر. So the validation, what about this? So this is the test. About the validation of this test, to test how sensitive, how specific. So there was a study published in 2013, included a small number or small size of patients with stage 1 or 2, according to the set with evidence of ATN. Threshomite given, as we mentioned at the protocol, and the progression, the outcome, the assess is the progression either to stage 3 with rising creatinine or urine output, or declining urine output, or receiving renal replacement therapy according to the Aiken criteria. And this is how they define the AKI progression. And this is the, by the way, the gray bar is the patient who did not progress to Aiken stage 3. And here, patient who after 2 hours who progressed to the Aiken. And we have here a good response of validation, and the sensitivity and specificity is close to 87%. So it's a good challenge test to assess the loop diuretic responsiveness. So just comparing the Threshomite challenge test with other AKI biomarkers, just I will highlight this quickly, also as because of the time, but this was interesting to assess, is it validated on contrary or in comparison to the biomarkers. And I know most of us like the labs and the biomarkers more the clinical bedside, but again, it was an interesting that to compare the FST or Threshomite challenge test versus the AKI biomarkers, and they found that in early AKI, the urine output after the challenge test can predict the development of stage 3 progression. Several biomarkers were measured in patients where AKI who received Threshomite challenge test like NGAL and other biomarkers. They evaluated the ability of the challenge test and the biomarker to predict the progression. The 2 hours urine output after the Threshomite challenge test was significantly better than each urinary biomarker tested in predicting the progression to stage 3. And this was statistically significant p-value when they found that the Threshomite challenge test was significantly better than the urinary biomarker. And sometimes if you know the biomarkers, sometimes not available, sometimes it's expensive, sometimes it's send out result and it takes time until you get the biomarker result. The Threshomite challenge test urine output was the only biomarker to significantly predict the need for renal replacement therapy, and this was published in 2015 to validate the role of Threshomite challenge test over the markers. Now I will move to one important entity, an interesting entity called diuretic resistance. The definition of diuretic resistance should be clear to us when to call this is a diuretic resistance. The same like insulin resistance, the same like heparin resistance. Yes, we have diuretic resistance. So the prevalence of diuretic resistance is about 20 to 30% among heart failure patients. So patients who are dealing with heart failure patients should be aware about the diuretic resistance, because about 1/3 of them, they develop a diuretic resistance. Despite its frequency, the term diuretic resistance remains inadequately defined. However, the diuretic resistance definition is still, as I called, inadequately defined, but there is a trial to have some simplified definition. So the diuretic resistance and pathophysiology, it's a failure to decrease the extracellular fluid volume despite the liberal use of diuretic. This is in general او المعنى الدارج يعني ايه diuretic resistance زي الهيبر resistance زي الانسولين resistance انه failure to decrease the extracellular volume despite the use of diuretics. لكن quantitatively the diuretic resistance is unsatisfactory rate of diuresis or natriuresis despite the adequate use of diuretic regimen. This is an quantitative definition. There is unsatisfactory rate of urine output or diuresis or natriuresis despite that you use adequate diuretic regimen. So there was a trial to delineate a definition since 1977 and defined that the diuretic resistance is a failure to excrete at least 90 millimole of sodium, which is a natriuresis effect within 72 hours. So you measure the urinary sodium within 72 hours of 100 to 160 milligram Threshomite twice daily. So this is the definition regarding the resistance. If the patient failed to excrete the sodium with this quantity within 72 hours of this dose of Threshomite, we call it Epstein definition of diuretic resistance. There is another definition in clinical settings, and this is a bedside, which the diuretic resistance can be defined or expressed if you have FANA or fractional excretion of sodium of less than, sorry, it's 0.2%. So this is the definition. And this is the mechanism of diuretic resistance, either pre-renal or pre-nephron, like the cardiorenal hemodynamic interaction and the decreased renal blood flow, or through the lobe of Henle itself is a pre-lobe of Henle diuretic resistance, or causes acting on lobe of Henle, or causes acting post-lobe of Henle. So, for example, if you look for the pre-lobe of Henle causes, reduction of number of nephron, reduction of GFR, the competition of diuretic entry to the nephron by organic ions, albuminuria. For the lobe of Henle itself, the lobe diuretic dose itself, the frequency, and the natriuretic response. While the post-lobe of Henle diuretic resistance causes is the distal tubule hypertrophy or hyperperfusion or condition or increased renal pressure. Here, how to have some strategies about treating the diuretic resistance. You have initial measures and you have advanced measures. The initial measures comprise intravenous use of diuretics with safe doses up to 500 milligram of oral Threshomite or 200 milligram of IV. It's a safe, and you can use alternatives. You use first intravenous, and of course in ICU we are not using the oral usually on outpatient basis or for ambulatory patients or in the floor. But intravenous diuretics usually in ICU settings, then you can move for increasing the diuretic dose, and we talk about the upper ceiling. You can use alternative lobe diuretics like the bumetanide or Threshomite, or you can move to the continuous infusion, and I will talk later about the bolus versus the infusion, intermittent bolus versus the role of continuous infusion. You can combine the intravenous lobe diuretics with one or more of the diuretics from different classes. And I told you before, earlier in the slide, the classes of diuretics. They have advanced measure if still there is diuretic resistance. You may have to start hypertonic saline. there was some thought about in the past, if you remember, the dopaminergic dose, and now is the so-called low-dose dopamine in treating the diuretic resistance. But since many years back, there is no role now for it. Increases the renal blood flow, but does not have a role in facts on the diuretic resistance. And there is also, they mentioned you can apply or use the Niseritide, but in clinical practice, there is no improvement in the urine output or hospital admission or mortality. And now it's discouraged or not recommended for using the Niseritide and treating the diuretic resistance. About combination of diuretic therapy, this is to have an effective or maximal dose of lobe diuretics. You may consider adding one of the following: distal convoluted tubule diuretics. You may use now I'm combining to lobe diuretics another class, which is the metolazone, between 2 to 2.5 10 milligram. Unfortunately, it's oral only. It's not available as IV. You may use hydrochlorothiazide. You may use chlorothiazide. One of those if it's available. You can move to another combination, which is the proximal convoluted tubules diuretics, which is the acetazolamide. And there is also IV and oral form of this, but again, it's a weak diuretics and have some drawbacks, but still there is some role with weak evidence in combination therapy for treating the diuretic resistance. The final class, which is also weak diuretic, is the potassium-sparing diuretic. We do not recommend it usually because it's oral, either amiloride or spironolactone. Plus, patients sometimes they are hyperkalemic, unpredicted the hyperkalemia response. So usually we rely mainly on the distal convoluted tubules rather than the in combination, mainly metolazone rather than the others. Just for tell about the doses regimen for continuous infusion of IV diuretics regarding the Threshomite and the bumetanide. This is commonly we use the Threshomite, bumetanide. I didn't think it's the Threshomite IV is available in Egypt or not, but commonly is the Threshomite and bumetanide. So the loading dose usually for all levels of GFR, they use 40 as bolus or loading dose. For bumetanide, they give 1 milligram. Then they go for infusion rate, milligram per hour, depending on the GFR less than 25 to 75 or more than 75. They start with 20, then 40. Bumetanide 1 to 2 milligram, between 25 to 75, 10 to 20. So here, if you lock for GFR less than 25, you may reach up to 40 milligram per hour. But still with GFR more than 75, but the patient is still with drug, with allegoric, with volume overload, just no need to increase more to 20 or 10, or 20, just go with 10 milligram. And the same for bumetanide. This is how can we address the diuretic resistance. Pre-final, we have to go through common methods about the IV furosemide. These are the common methods. Now there is a one brainstorming to wake up. Please, guys, this is an MCQ. I need your answer. And I hope the previous MCQ was answered already. The answer previously was D. So people who answered D, it was correct for the first MCQ. This is the second MCQ. A 70-year-old male with a history of hypertension, coronary heart disease, benign prostatic hyperplasia, get admitted to the ICU after partial colectomy and liver resection for colon cancer. Placement of Foley's catheter was challenging due to his enlarged prostate, some hematuria, plus patient developed persistent bleeding from the abdominal drains over the night. He remained anuric for 6 hours. Which was not identified until morning. His vitals, heart rate was 110, blood pressure 80/45, heart respiratory rate 25, and saturation 100% on 2-liter oxygen. His latest lab value, hemoglobin dropped to 5.6, urea 24, creatinine 1.8. 3 units bagged RBCs and 1 unit fresh frozen plasma were transfused, and the surgeon was notified for the bleeding. He is taken now to the OR, where his surgical bleeding is identified and repaired. During the OR, he received 2 liters of crystalloid, 2 units of FFP, and 2 units of platelets, but his urine output did not improve despite the volume resuscitation. In the next 12 hours, his vitals are normalized, but the patient remained anuric. The question is, which of the following is most likely to prevent the need for dialysis, to prevent the need for renal replacement therapy? A, mannitol IV, B, Lasix infusion to treat his liguria, C, dopamine infusion 3 to 5 mics per kg per minute, and D, none of the above. Just in 1 minute, I need some volunteers. A or B or C or D?
B.
B.
B. Any answer, volunteers? يا شباب.
D.
D. 10 seconds to have more one answer. Okay, the following methods will answer my question. So you will find the answer here in the following method. So method number 1, the furosemide cause AKI. So this is one of the common methods that usually we face it during the discussion or during the round. So does the furosemide cause AKI? No, does not. The furosemide is particularly useful in patients with volume overload. So I'm stressing and highlighting volume overload. Few studies have identified that diuretic use has a risk factor for AKI. Most of the report did not distinguish between different etiologies of this AKI. And I have to stress and to mention that the inappropriate use of diuretics in the settings of hypovolemia will, of course, contribute to the development of AKI. This goes without saying. You did not use, if you will use the diuretics without judgment or without wise use in the settings of hypovolemia, of course, this will develop the AKI or will fasten the progression to AKI. When used appropriately in patients with volume overload, the IV furosemide may resolve the AKI. What's the mechanism for this? If there is a role for resolution of AKI by furosemide, by resolution of the intrarenal congestion, and if you remember, this was one of the effects from before in the previous slides. The second mechanism is reducing the renal oxygen consumption. This is, again, in the volume overload. The second myth, the furosemide and the fluid together can prevent AKI in high-risk patients. Is it yes, no, or probably no? So it's probably not. There is a common belief that the co-administration or the combination of giving furosemide and fluid, it will increase the diuresis without causing hypovolemia. And this was addressed in many circumstances, like the tumor lysis, like the contrast-induced nephropathy, and they have the so-called renal guard device or automated matched hydration system that using the diuretics and fluid together for the prevention of the so-called contrast-associated AKI. When you do images like CT angio, coronary angio, or angioembolization, and the patient is at high risk of CA AKI or contrast-associated AKI. While some authors, they found a reduction in the incidence of contrast-induced AKI, some studies in patients with AKI did not demonstrate the benefit. So it's still contradictory results about the effect on the progression of AKI. So the fluid, or in conclusion, the fluids should be considered as therapy for patients with hypovolemia, while the diuretics should be reserved for patients with volume overload. So this is the final conclusion or final recommendations. Myth number 3, the furosemide is contraindicated in patients with AKI. Yes, no, No, it is not contraindicated. The furosemide is indicated in patients, again, with volume overload and hyperkalemia, including those with weak AKI. So if you have patient with weak AKI and have both volume overload and hyperkalemia, there is a strong indication here to use the furosemide. The higher doses of furosemide may be needed. There is higher doses, I'm talking about above 200, sometimes they reach 500, especially in severe AKI where the risk of diuretic resistance is higher. Furosemide can be used as a diagnostic test or a diagnostic tool, and it's well validated in AKI, which the FST or furosemide challenge test when assessing the tubular function and the risk of progression from stage 1 to 3 of AKI. Myth number 4, furosemide can kickstart the kidney function. Yes or no? No, it is not the case. Furosemide may lead to significant diuresis in patients with AKI. This indicate the function of the tubular cells rather than direct beneficial effect of the furosemide. So either you have functioning tubular cells or you don't have functioning tubular cells. Repeated doses of furosemide or higher doses than the recommended, especially in aneuric patient, may be harmful and lead to significant increase in the morbidity and side effects, mainly the ototoxicity. In patients with volume overload who are not diuretic responsive, based on the fluid challenge, on furosemide challenge or furosemide stress test, there is no role for repeated furosemide administration. So you can do it. It's a bedside, it's easy test, well validated. We have significant sensitivity and specificity. So in patients with volume overload who are not diuretic responsive based on the challenge test, there is no role for keep giving furosemide or keep giving repeated furosemide. I know some of the nephro, they likes the furosemide and they are keep pushing you. There is no need for dialysis patient still. There is no hyperkalemia. There is no metabolic acidosis. There is no strong indication, but the patient, you know that you are bedside and now for more than 24 hours or 48 hours, there is no response to furosemide. So why you continue? And you did the challenge test. And here the extracorporeal fluid removal by renal replacement therapy should be addressed early, either renal replacement therapy, whatever the mode you will use, SLAD, CVH, arterial whatever. The next myth, does the furosemide works better if given with albumin? Also, this is another approach. It depends. Furosemide, as we know, it's highly protein bound. The severe hypoalbuminemia is associated with impaired furosemide secretion into tubular lumen, and this is one of the causes implied or identified in diuretic resistance, the hypoalbuminemia. So the evidence supporting combined the use of albumin and furosemide still is sparse as evidence-based, I mean. In patients with liver cirrhosis, ascites, the co-administration of loop diuretics and albumin, which is 40 milligram furosemide and 25 gram of albumin, did not enhance the natriuretic response. There was meta-analysis including 10 studies demonstrated better control of fluid balance with co-administration of furosemide and albumin in hypoalbuminemic patients. So now, and based on this meta-analysis, in patients with hypoalbuminemia, the co-administration of furosemide and albumin, it may have a better control for fluid balance and natriuresis. While in patients with normal albumin level, there is no direct beneficial effect in the combined infusion. So do not use albumin and Lasix with normal albumin level. Next myth, number 6, the furosemide infusion is more effective than boluses. And this is the daily practice, the daily challenge, the daily dilemma, the daily discussion between you as an intensivist and the nephrology. Is the furosemide infusion better and effective than boluses? Yes or not? Based on the evidence-based? No, it is not. No, it is not. Some people, they say, okay, it's my experience. Yes, I respect my experience. But on the other side, respect some evidence-based respect people who address this issue since long time through several RCTs and meta-analyses. They showed that sustained diuresis is easier to achieve with continuous furosemide infusion compared to intermittent bolus therapy. This is regarding the sustained diuresis, but there is no evidence that there is better outcome, including the mortality, length of stay, effect of renal function, or electrolyte disturbance. Again, both are equal. So if you come to the outcome, the mortality, the length of stay, the effect of recovery, the electrolyte disturbances, the continuous furosemide versus intermittent is the same. So do not push for people who are, or do not blame people who are using intermittent like 40 TID or 80 TID or 100 TID, whatever the dose ceiling you have, or people who are using 10 to 20 milligram infusion based on this for better control of diuresis. Yes, but if you look for long-term outcome, as per stay, cost effectiveness, there is no difference. Next myth, number 7, does the furosemide can prevent the renal replacement therapy initiation? No, it cannot. The furosemide has a role in diuresis in patient with volume overload, as we mentioned. If the patient is diuretic responsive based on the FST or the challenge test, the administration of furosemide may buy time only before the initiation of renal replacement therapy or before developing of loop diuretics, just buying time. There was a meta-analysis reported that the administration of loop diuretics was associated with shorter duration of renal replacement therapy from 2 to 3 days instead of like 4 to 5 days. However, the furosemide use has no direct effect on the chances of renal recovery. This is very important. And based on the SPARC study, compared the low-dose furosemide versus placebo in early AKI and found there is no difference in the rate of worsening or progression of AKI or the need for renal replacement therapy. Next myth, number 8, does the furosemide helps to wean the anuric patient from renal replacement therapy? Patient now is on renal replacement therapy, and we can use furosemide while there is clotting of the filter or giving a break. But the patient is anuric. Does this help to wean anuric patient from renal replacement therapy? It does not. In patient treated with renal replacement therapy, increasing diuresis is a common reason after discontinuation of renal replacement therapy, and diuretics are frequently used for this purpose. There is no evidence that the diuretics are effective at improving the creatinine clearance or inducing renal recovery. There is an increased risk of furosemide accumulation, and this will lead to higher incidence of ototoxicity, and especially in anuric patients. Myth number 9, that the furosemide induced diuresis after AKI implies a full renal recovery? No, it does not. Why? Because while furosemide administration may lead to increased the output, in patient with AKI, the furosemide induced diuresis must not be considered a sign of full and permanent renal recovery. Even patients who experience a single episode of AKI and recovered their excretory function, they remain still at increased risk of CKD and increased mortality. Myth number 10. Does the furosemide should be stopped if the serum creatinine is increasing, indicating worsening of renal function? And this is, we face it a lot. Patient with AKI who started furosemide, there is worsening of renal function. Should we stop the furosemide based on this? No, it's not necessarily. Many patients with acute heart failure, they may have rising creatinine or by 0.3 milligram or more during their diuretic therapy. It's not a sign of true worsening of renal function or associated impaired outcome. The isolated increase in serum creatinine in combination with hematocrit may be a sign of reduction of the intravascular volume or hypovolemia and effective decongestion. So consider when rising serum creatinine daily and hematocrit, this means that you are in the verge or the wedge of volume depletion and effective decongestion, so be careful. It may be also associated with better outcomes called pseudo-worsening renal function, so consider it as a better sign. A similar effect was observed in the FACT trial with ERDS. The restrictive fluid therapy using the substantial diuretic dose improved the weaning from mechanical ventilation, but was associated with increased serum creatinine. So there is benefit of weaning from mechanical ventilator, but on the expenses of increasing the serum creatinine. Also, the requirement for renal therapy was lower in the group of restrictive fluid therapy. The last myth, or myth number 11, for furosemide resistance. If you diagnose the patient have furosemide resistance, should you add metolazone, chlorothiazide, or tolvaptan? Yes, but you have to judge. Thiazide diuretics are effective in releasing or treating the resistant to loop diuretics as a second line, but not a first line. For patients who are refractory to loop diuretics, oral metolazone appears to be equally effective as IV chlorothiazide as add-on loop diuretic without increase in safety concern. And for oral metolazone, it has a better, one of its advantages, it has a better bioavailability. Also, it has a reduced cost and longer half-life. Regarding tolvaptan, for tolvaptan, it results in excretion of large volume of water. It does not seem to be ready used or routinely used in critical care settings. Number one, for uncontrolled water removal. The rapid rebound water retention after discontinuation, and this is one of its major disadvantages. The intracellular dehydration rather than the extracellular decongestion. I will finalize and to sum up tonight my lecture with some tips for effective diuretic dosing in setting of AKI. This will often need higher doses, especially in patients with prior furosemide exposure when the GFR declines. So you go for higher doses if the patient was treated before with oral furosemide, for example, or bumetanide. Furosemide 200 milligram is a ceiling dose. With some literature, they may use up to 500 milligram, but the recommendation now for ceiling dose is 200. There is no clear evidence that the infusion is superior to intermittent doses. As I told you before, consider concomitant use of diuretic that inhibit the sodium absorption in distal convoluted tubules like metolazone. And this is a practical guide, for I told you regarding the use of diuretic resistance approach. Here, the clinical effects of furosemide therapy in critically ill patient, I have to summarize with this slide. If you need to come up or to come out with take-home message from tonight's lecture, this is the slide, summarizes the clinical effect of furosemide therapy. There is some benefit, no significant difference, or you are adding some harm. If you have patient with diagnosed AKI or patient who are at risk. So if you need to ask me, is it beneficial? Yes, furosemide is beneficial in high-risk patient with volume overload. It's beneficial when you co-administer with albumin in hypoalbuminemic patient and in direct resistance. It's beneficial in patient diagnosed to have AKI with volume overload. So those are the three beneficial effects of furosemide. What about, there is no significant difference. There is no significant difference for continuous versus intermittent infusion. Both are equal. And there is no significant difference regarding the weaning from or weaning of the renal therapy in anuric patients. Adding to harm, and we don't want you to harm, do not use furosemide or diuretics in high-risk AKI patient without volume overload. Do not use furosemide in patients with developed AKI without volume overload. If you use here, you are on the harm side. If you will ask me what some resources or suggested resources you need to reference or to have to read it back, so I recommend this article published in Intensive Care Medicine Journal 21, a narrative review about acute kidney injury in critical ill. It's a very nice narrative review. It's an updated review about the pathophysiology and the management. So I refer all people who are going for fellowship, MD, master, even حتى for clinical practice, to download this narrative review. Second, this is also a narrative review from the Critical Care Clinics magazine, published also 21, regarding the sepsis associated AKI. A very nice review, a narrative review, to the point. You can have it so you can cover this entity. And also this nice editorial, only 2 pages, summarize my methods that I presented to you, the 11 methods, also published in the Intensive Care Medicine Journal of the European Society 2019, and the title is 10 Methods About Furosemide in Critically Ill Patients. By here I conclude and I sum up, I finish my talk. Thank you, and I apologize for exceeding my time limit, and I'm ready for your question. Thank you, Dr. حسن.
شيقة جدا، وانا استمتعت بيها شخصيا واستفدت كمان وتعلمت. حتى انا عملت رسالة من 7 سنين مع الدكتورة مها عوض، هي حاضرة معانا، مع الدكتورة حياة حرجة، كانت على فعلا فورسمايد ستريس تيست، واثبتنا الفاليا بتاعته، واتخذت كريفرنس في كتب الابديت. لو انتوا تلاحظوا ان احنا كنا نشرناها كابستراكت. الحقيقه يعني طبعا مفيش وقت للاسئله، بس انت كنت يعني موضح بطريقه تفصيليه